Good afternoon to everybody. As Ava said, my name is Andy Houghton and I am currently the old man of Haemoglobinopathy clinical nurse specialist in Liverpool. As Ava said, I've been a haematology nurse for 30 years and became a clinical nurse specialist back in 2000. My first job was leukemia research. I then moved on to be the transfusion practitioner, and in 2012 became the first haemoglobinopathy clinical nurse specialist for adults in Liverpool, which with a joint role of transfusion for a couple of years, and now this alone. I did retire in 2021, did a retire and return, came back after a month, reapplied for my old job actually because I realised that I was going to stay. So now you can hear that my hospital is burning down. I do apologise. I'll switch that off for a second. I think that was just a test, although all the fire door. If you see flames and smoke, I might leave, but we should be okay. So yes, so I've been asked to do a talk today about blood transfusion in sickle cell disease. So we'll move on. So I've done lots and lots of talks over my 30 years of nursing, and I've even been over to Ghana, and there's a picture of me doing some teaching over there. But as you can see, the difference, it was face to face. And I enjoy face to face because I can see the reaction of people and we can communicate and ask questions. But as I've said, I've retired. I'm an old man now. These newfangled computers that we do and online talks sometimes get me a bit over it. So we'll see how we can do with the new technology, and just do bear with me, and hopefully we'll have a bit of time at the end for some questions. So one of the things I've just put, this is a slide that I used to use when I was a transfusion practitioner back in about 2005, when we used to do our mandatory training to staff, and it was just basically talking about the risks and benefits of transfusion, and there still is risks and benefits, and we'll go a bit further. But I just wanted to bring this slide up from many years ago that I always used to use, because I think my job in the olden days with transfusion was trying to scare people to use as little blood as possible. And obviously every clinical decision was, yes, the person needs it because of all the risks. And there we've got things that we know about hepatitis B, hepatitis C, HIV, which is particularly pertinent at the moment, given the ongoing infected blood inquiry. And one of the things that when Ava said I tried management, I was managed the department for a couple of years, and during that time it was when the infected blood inquiry was starting and sending some of the data we've got for our haemophiliac patients, etc. But it does bring it home that there are risks associated in just using that bag of blood. These figures may well have changed because they were taken from a presentation that's quite old, but we know about all the infective issues, you know, HIV, Hep B, Hep C, CJD, and other things. But there's also some immunological issues, and that's going to hello, and that's potentially going to be more in relation to this talk later on. There's also human error, and we should always make sure that the benefits of the blood that we're going to give outweigh the risks. And with our group of patients, that's probably pretty clear, but we still have our role to document and ensure that we follow that. So, transfusion therapy. Why do we do it? What are the goals? Well, I'm focusing specifically on sickle cell disease here and not thalassaemia, because in Liverpool, our practices, we've actually gone from about 20 patients when I first started to just over 100 now patients with sickle cell disease, and that's increasing. But we only have a handful of thalassaemia, major or intermediate patients who require transfusion. So we're focusing on sickle cell disease. So the goals of the transfusion therapy are to improve the oxygen carrying capacity by increasing the hemoglobin level. And obviously we know in relation to sickle cell disease that, you know, the name sickle cell anemia ties in, that anemia is a big issue with our patients just due to the destruction of the red cells and the production of red cells. And also decrease the blood viscosity and increased oxygen saturation by diluting the high concentration of hemoglobin S. Again, when we're looking at whether it's simple or exchange, we have aims of what sort of hemoglobin S level we're aiming to do, and also potentially to suppress some of the production of the sickle cell red blood cells. And ultimately, it's the idea is to prevent or resolve vaso-occlusion. So, you know, we for secondary stroke, and we'll talk about that, we're trying to prevent any reoccurrence, or a patient who may be going for major surgery. Obviously, we want to minimize any of the post-operative complications due to the sickle cell disease, etc. So what are the indications? Why do we do blood transfusions? And there are lots, and I do apologize that these are quite busy slides, and I tend to find that when I'm doing things online, it's there because of the slight lack of interaction. But one of the first issues is cerebral vascular disease. So we know that people, one of the biggest guidelines, and why we have currently 7 patients in Liverpool who are having long-term red cell exchange transfusions, and 2 of them are in relation to previous stroke as juveniles, actually. So so there's an indication for long-term transfusion hemoglobin S level less than 30. So basically, from the hemoglobin S levels, we're trying to reduce that down to what would be a carrier, or even less than a carrier. And this is recommended. And these are just taken from the most recent BCSH guidelines. So these are the guidelines that we should be following. And also, we should potentially be auditing our practice also against these recommendations. So we know that stroke is a major indication for continuing or commencing and continuing with potentially lifelong transfusion. Also, there's another big indication in surgery, and later on, I'll be doing a case presentation which resolved this. But we know, obviously, for a patient undergoing surgery, and especially if it's moderate or quite severe, and there's potentially for a long period of general anaesthetic and bleeding and other, you know, perioperative complications, that we want to try and make our patient be as best prepared as possible from a sickle cell disease point of view. So there's guidelines for patients receiving surgery about when and how we should transfuse these guys. So for anyone who's undergoing a medium risk surgery, and it's abdominal tonsillectomy, orthopedic, and if you certainly look at the abdominal with patients with SS, you know, the number of cholecystectomies that we are doing for our patients. And although the vast majority of these are aimed to be done laparoscopically, we know that they cannot be guaranteed that a laparoscopic procedure will not end up being an open major abdominal surgery. And also orthopedics, and again, I'm sure all of us that look after people with sickle cell disease are unfortunately only too aware of the amount of patients that unfortunately will require some sort of joint replacement due to avascular necrosis. So it's recommended for those patients with SS and some patients with SC who are undergoing the medium risk. All patients of all genotypes, so whether it be SS, SC, S beta, Thal, who are having high-risk surgery, so if there's any cardiovascular surgery, and we've had a couple of patients in the past who've had valve replacements or brain surgery or anything that's a long time. We actually had a patient a few years ago who had an aortic aneurysm repair, which certainly for our anaesthetists here and doing literature searches was the first that we could find that we would do a red cell exchange. One of the things that can be a bit interesting is in the relation to emergency surgery. And again, that needs to be basically taken on a patient basis of how urgent the surgery is in relation to how we can prepare that person. So that would need to be the conversations, obviously, between the surgical, the anaesthetic, and the haemoglobinopathy team to decide what is the best outcome or the best plan for that patient. Also, there's indications for your acutely unwell patients. So We know that with sickle cell disease, it's a condition that can basically affect any organ in the body, and it's one of the things that when we're talking to people who don't know a great deal about sickle cell disease, and it's, oh, your patient looks fine, but actually we know that there can be multi-organ failure, or there can be events and crises, that vaso-occlusive crises, that can affect basically any organ in the body. So we can get some of the things where splenic sequestration or hepatic sequestration, aplastic crisis, or a severe acute chest syndrome. And again, depending on the severity of these, there is recommendation and guidance that transfusion may well be appropriate for these patients. And as I've said again, there's set things that we're aware of, but there's always patients that can throw up different things that aren't as common and are quite rare, that transfusion may well be appropriate for. And these are the things that we would talk to the specialist teams. And also in some of these circumstances, this is why we now have developed throughout the country local haemoglobinopathy teams, specialist haemoglobinopathy teams, and also coordinating centres and the national panel, so that we have different levels of expertise, so we can hopefully talk to each other and ensure that we have the best treatment and the best outcome for our patients. There's also guidance on pregnancy, and in pregnancy, prophylactic transfusion isn't currently recommended, and this is, as I said, from BSH guidance, and this is for the UK. But I know that we have had a couple of patients who come over from Europe who, for no other real indication other than being pregnant, were on transfusion regimes. And it's quite difficult to then discuss with patients about someone who's been started on one treatment by a group of physicians in one country and coming over here. But at the moment, there's no routine guidance for prophylactic transfusion. Obviously, if ladies who are pregnant have got previous comorbidities, stroke or recurrent acute chest, or for whatever reasons, we would potentially continue the transfusion throughout the pregnancy. Excuse me. So, and again, nice little things. These are just summaries of what I've said and taken from the BSH guidelines about, these things are there to guide us and also to obviously show us how to practice, and also to audit against, to make sure that we are following what is the best guidance. So I've just taken these as a brief guide from the BSH. As you can see, my cutting and pasting wasn't particularly uniform with those two pages, but that's a table that can be found in the guidelines from, I think, 2016 they were. So we'll talk about indications for transfusion. We know transfusion is required. We know as long as there's good evidence that that patient will need required transfusion, that ties up the risk management part of, does the patient need it? Yes, they do. Okay, but what are the types of transfusion? And there are different types of transfusion. There is the intermittent or the chronic. So there's people who can be on a long-term regime, but there's also emergency and urgent transfusions. And there's methods of doing these as well. As we all know, there's either the simple transfusion or the exchange transfusion. And I've just explained a little bit more about those. I know most people here will know what these are, but again, just for clarification. So a simple transfusion. The thing before we start all these modalities and methods of transfusion is, how do we get them into people? And it's intravenous. I don't think there's an oral blood tablet yet, fortunately, or anything like that. This is all intravenous, and we know with our specific group of patients, IV access can be quite an issue. So it's all well and good, easy saying, oh, we need to do transfusions, we need to start this treatment, we need to start that. But, a big issue with our patients is IV access. So certainly when we're considering any long-term or repetitive regime, we need the discussion about access, and then we need to potentially use our colleagues in the IV access teams or interventional theatres, or to see that we can have the most appropriate form of IV access so that we can do the treatments. So a simple transfusion is what it says. It's a bag of blood. It's looking at people sitting in hematology or medical day wards or wherever, sitting in a chair with a cannula in or a PICC line or a line in and having a bag of blood. So it's relatively widespread available. You don't need any particular machinery. You need, obviously, staff, and staff do need to have training. And like with lots of things, there's certainly a big thing about blood transfusion competency training because of human errors and things that have happened, and also the introduction of the SHOT specialist hazards of transfusion group and MHRA, that there is need for the appropriate competency assessment for staff. But, you know, it's relatively straightforward for trained staff to be trained. Minimal specialist treatment, it's basically a line, a giving set, and a pump, and it can be done in a medical day ward or a day ward. It is time consuming because depending on comorbidities with the patient, you're probably talking about 2 to 3 hours per bag infused, potentially a bit quicker with some patients, but you would talk about that time. So by the time the patient comes into the hospital, if it's anything like our brand new lovely hospital in Liverpool that's got less beds than the old one, and also even less parking facilities, it can be a full day out just actually arriving in the hospital, finding somewhere to park. So it can be time consuming. Because we're putting blood in and not really taking anything out, there is a risk of viscosity. And, you know, we need our patients to have a maybe slightly lower hemoglobin to start there, because with most patients, certainly SS patients, we don't want to be transfusing people to hemoglobins greater than 100 grams per litre on a regular basis by any stretch of imagination. It's also difficult to, as closely control hemoglobin S levels, because again we are putting blood. And also the other thing with bags of blood is, you know, there can be a great variation between every single bag of blood. So you can have a bag of blood that might have 250 mils in, 220 mils, and another bag of blood that could have up to 350 mils, because obviously they're taken from individual donors, and it depends what the donor's hematocrit was to the amount of packed cells that are going to be available in there. The other big thing at the bottom there is obviously about iron accumulation, and I'll talk a little bit about that as we go on. So there's a simple transfusion. It has its place, and there are patients that will have simple transfusions or top-up transfusions in probably most of our units, and it is quite effective if it's right. But again, it's looking at every patient as individual and making sure that we plan the care that is appropriate for that patient. So the next mode is an exchange transfusion. So you're exchanging it. It's a manual exchange. And this is obviously, again, taken from guidelines, and talking about it is widespread available. I can say hand on heart that I have never been involved. And at Liverpool, we've never, or certainly I can't remember us having to do a manual exchange transfusion. And one of the reasons for that is that we are lucky enough to have NHS BT on site in Liverpool. And for our patients, with our number of patients, if we required exchange, we've always managed to have an automated. But I'm aware that in some senses, this may well be the quickest and the best way to do this. So again, it's could be widespread available. There is some training that will be needed for the staff, because it's not just a case of connecting a bag of blood. We are exchanging, we are taking blood off via venesection and replacing it. It is very time consuming for the patients and the staff. The viscosity risk associated with the simple transfusion is reduced because, again, we are taking some blood off. There can be some control with the hemoglobin S, but again, you know, it's, as it says, it's probably an intermediate control when we look at the other modality of doing an exchange transfusion. There is some iron accumulation, and again, it's a longer process. And if drawing off, you know, the IV access normally has to be a little bit more robust than receiving a simple transfusion. And then obviously, the other way is the automated red cell exchange. And as I said, we're lucky in Liverpool, and we have for several years had the National Blood Service apheresis team who are based on site. So we are have them for 24-hour cover as well. So if we need one in the middle of the night for an acute chest or for whatever reason, that providing that we as a hospital, as a team, do all the appropriate things to allow the team can come and perform that red cell exchange. It is limited though. Everywhere I'm aware is not quite as lucky as to have that here. Although I know that at Manchester, who do have a huge population of patients, have just managed to have the National Blood Service supporting their on-site team. That is good. Obviously, there is significant staff training. I've seen many red cell exchange. I've looked at that machine, which is in that photo, on several times, but I would be the last person in the world you'd want to operate one, wouldn't have a clue. So there is obviously specialist staff that need to use that equipment, and there's obviously, we need that specialist equipment. An exchange can be done relatively quickly, about 3 hours or so. The guys can get that done because it's monitored, and we would hopefully have S levels and hematocrit and HB levels beforehand. Our guys in the NHSBT can program this into the computer, and it can do wonderful things and almost come with the results that we are aiming for. So it's the best control. It reduces less risk of hyperviscosity and the issues that can cause. We can aim to get our S levels down to below our 30 or whatever. And I've got lovely little graphs of all our patients who are on red cell exchanges, and the results are normally excellent with what we've got it. There can be longer intervals between treatments, but again, that's an individual. We've got patients who are requiring 4 weekly exchanges because their S level increases quicker than some that are having 6 to 8 weekly. The iron accumulation is less, but one of the issues, again, this is quite a big, powerful machine, is the IV access. And the vast majority of patients do need central access. So we, at the moment, are using femoral lines. And I think we've got one young guy who's probably had about 40 of these during his process. We are considering, or we are looking towards potential use of ports. And I know that's used in some areas throughout the country for automated red cell exchange. And we're trying to work with our colleagues in an NHSBT to see if that's something that we can do. So there's different indications. We know when patients need it. We know how we do it. So that's it. It's safe, isn't it? What do we do for patients? So when we see our patients in the first instance, we should obviously do a history. We do a full history anyway. And part of that history is transfusion. Have you been transfused before? Yes or no? And there's certain bloods that we should do. So we should all try and make sure that we're doing an extended red cell phenotype or genotype. And the NHSBT now have a system called SPICE. So there is good movement with patients throughout the UK. We're seeing a couple of patients in Liverpool from London because they're at university here, and vice versa. So once this has been done, this should be available via the NHSBT SPICE. So as part of our baseline, when we see people for the first time, we'll do some transfusion samples and get that sent off for future reference. There's also recommendations, again, via the BSH about blood product selection. So it's not just a case of going and grabbing any old O positive, O negative, whatever the ABO group is. These are closely matched. There's also, we all know about our basic ABO system, A, B, O, A, B, and the RH system. But again, as a transfusion practitioner, I used to love, especially when I was doing a talk for medical students, to throw up a list of all the other red cell groups and antibodies and antigens, just to say how complex it is. So we know there are differences. So there are recommendations that laboratories follow to make sure that we match blood for our sickle cell patients slightly closer. There's also certain subtypes that we are aware, such as the RO blood group, that tends to be more prevalent in people from different ethnicities, and certainly in people from an Afro-Caribbean background, that will require certain blood groups and certain blood subgroups, yet the percentage of donors that will have this because of the reduction in some certain ethnic groups donating blood can make that difficult. So we need to try and make sure that there's enough of a blood supply and that we get the appropriate matches. Obviously, HBS negative blood is a no-brainer. And also, with all our haemoglobinopathy patients, we try and ask for the blood to be as fresh as possible. So we would try and aim to get any units that have been donated within 7 days, if that's possible. And again, with the number of patients that we have at Liverpool and with our planned red cell exchanges and our planned top-ups, we can send a spreadsheet to the laboratory with a very, a basic idea within a couple of days of when we'll be requiring blood. So hopefully they can order in the most appropriate blood for us. So we know that people need bloods. We know what is the best way to administer this blood. We know that the laboratory are doing their bit to make sure that they've got all the information. But what are the issues associated with it? So again, with my transfusion practitioners old hat on, the first bit is the acute transfusion reactions, and then there's iron overload, there's resources, which I briefly touched on, and then there's something which I'm going to finish off about with some delayed hemolytic transfusion reactions and hyperviscosity. So with anything, with crossing the road, with taking 2 paracetamol, there are risks associated, and the most certainly are also risks associated with blood transfusion. So again, this is one of my old slides. This is something that was from the BSH about acute transfusion reactions. And, with our patients, sometimes you can almost become a little bit blasé if someone's having regular transfusions, if someone with thalassaemia or Diamond-Blackfan anemia or whatever's having transfusions every 2, every 3, every 4 weeks, to forget about the basics that you would teach to anyone about patients who are maybe not having transfusions as often, is that acute transfusion reactions or human error can happen for anybody, for any unit of blood at any time. So this is all part and parcel of the competency of the staff who are administering your blood transfusions to make sure that they are aware of any potential reactions. And those of us that have worked on hematology wards, certainly in the olden days, like I was back in the 90s when we were giving transfusions and putting blood through these big huge filters, some of these urticarial rashes and the minor transfusion reactions would happen almost about 50% of the time with patients. So it's been able to identify these things, and then obviously the National Blood Services start to do white cell depletion on the units, etc. So they have reduced the risk, but nevertheless there still are risks. So we need to understand that, looking after these patients, whether with the nursing staff or the medical staff, or even discussing with our patients, that there are potential risks. And I know that one of the things that we always used to say to people is there was sometimes people mentioned or patients mentioned a feeling of impending doom as there was a potential of a transfusion reaction occurring. And I always liked that little phrase, impending doom. And when I used to set questions for some of the nurses and some of the transfusion competency, it was always one of the things, and you could tell the people that listened to me were the ones that wrote impending doom in one of the little answers. So we need to be aware of that and how to react and how to deal with such reactions. And they are from particularly mild, and we also know that a transfusion reaction can be potentially severe and life-threatening. So this is just part and parcel. So as well as us knowing as staff, if we discuss with our patients, if you feel anything, if there's any changes whatsoever during your blood transfusion, please let us know. Sorry, I'm going through lots of things. As we know, certainly with the simple transfusion, but even with all modalities of transfusion, iron overload is a big issue. And if we were talking about our patients with thalassaemia or Diamond-Blackfan, or patients who are having, regular transfusions and for life, basically, we know that iron overload is one of the biggest, if not the biggest issue associated with that. Not to the same extent in sickle cell disease, but if patients who have been transfused, I think it's normally greater than 10 or 20 units, then we know that the potential for iron overload. And there's recent guidelines that have come out, and there's only one slide on that because iron overload is about 5 talks in itself to discuss that. But our patients who are on regular transfusion regimes should have a MRI assessment to check for any evidence of cardiac or liver iron on a regular basis. If patients are on a manual exchange and automated exchange, as we know, because the iron burden is reduced, we should be checking ferritin. And if there's any particular trends, and we know that ferritin can be very reactive as well, but over time, if there's trends, then you would treat with an MRI as the results would indicate. So if it's evidence that there is potentially iron overload, then we need to start monitoring these patients to see the level and then consider any potential chelation treatments. As I said, I'm going to leave it at that. One, because I'm certainly not an expert in that, and it would take a long time to discuss that as well. Resources. We know that, again, issues around transfusion are resources. We know that ethnicity in patients plays a major role in haemoglobinopathies, as it does with donors. And if you go on the National Blood Service, just excuse me, website, which is www.blood.co.uk, there's big sections about trying to improve blood donation within certain ethnic groups. And we've got one of our biomedical scientists here at Liverpool who actually won a big BAME healthcare award last year. And he does an awful lot of work in his own time. He has the charity going off doing talks about trying to improve donation. And in Liverpool, we have a big African culture musical festival every year in June. And he's there each year. And I think last year he got about 100 people sign up to potentially become blood donors. And I've done a few sessions, and when I've done a few awareness sessions in the community about sickle cell disease, and lots of people have said, how can we help? How can we help? And one of the things, for someone who doesn't have sickle cell disease but wants to try and help is please think about becoming a blood donor or a stem cell donor. We need more people from all ethnicities to donate blood. And it's highlighted with, some things that were happening nationally last year when there was a big worry in the news. And obviously, as healthcare professionals and people involved in hematology, I'm sure we were getting all the emails and letters ourselves, that there was a worry about the safety of the nation's blood supply. And we were getting letters in relation to us about reconsidering the amount of blood that we're requiring for red cell exchanges, maybe changing the HbS levels or the frequency just because there was an issue. So that wasn't just purely down to the lack of donors from different ethnicities. That was down the security of the blood, the amount of blood we had as a nation. So these are things that we need to think about. And moving forward, if from our own practice in Liverpool, if we look at the numbers who we've gone from 20 to over 100, and the children population is a lot more. If you look at the numbers in Manchester, you look at the numbers in London, if you look at the numbers nationally, our patient pool is increasing. So potentially the need for blood in the future is going to obviously increase as well. And as we start to have better treatments, the survival rate will be greater. There will be people with haemoglobinopathies, with sickle cell disease, maybe requiring more surgical interventions with preoperative assessment in the future. The resources, the amount of blood that we have to do this is going to be very, very crucial. So the big thing is to more donors. On the flip side, one of the other issues with the amount of blood that was available at the time was also a staffing level within the NHSBT, is that if you've obviously a finite amount of staff to collect the blood, you can only collect a finite amount of blood. So there's big issues with that. So resources are an issue. This is why we need to make the correct clinical decisions and make sure it's only the right patients who have the right blood, right modality, right frequency. And then we're moving on to other issues in relation to transfusion for our group of patients. And one of the big things that can cause major issues and can potentially lead to major life-threatening issues is the delayed hemolytic transfusion reaction and also hyperhaemolysis. So these are conditions where there's a breakdown in the red blood cells. So one of the definitions of the delayed hemolytic transfusion reaction, and this, you know, there's a hint in the title, the delayed. This can happen anytime, and some of the documentation says up to 21 days post. So this will be somebody who's having a remarkable drop in their hemoglobin. There's no other major reasons. There's no bleeding, whatever. There's normally hemoglobin urea associated with that. With delayed hemolytic transfusion reaction, there tends to be a new red cell allo antibody that can be identified, a rise in hemolytic markers, LDH, etc. And these can be quite dramatic. These can be hemoglobin levels that drop, you know, very, very low and seriously low, and in some cases life-threateningly low. And hyperhemolysis is a very similar sort of picture. It would tend to occur sooner, and there's not always the evidence of a red cell antibody. But one of the things that you would potentially look out for and identify this is that for a transfusion, we would hopefully know what the pre-hemoglobin level is. And these are patients who, when there's evidence of this drop in hemoglobin, is that hemoglobin is lower than the pre-transfusion level. And it's identifying to of that donated of the autologous of the allogeneic blood that's been transfused, but also there can be issues in relation to the patient. So these are very, very severe issues, and these are things that people need to be aware of. And again, these can be some of the problems that if you have hematology ward and you are confident that your staff looking after our patients are competent in all, or certainly most, but hopefully all aspects, including transfusion and what can be some of the issues, you delayed transfusion or hyperhemolysis, that if a patient's having a transfusion and then comes and, oh God, I've just been past some urine and oh my God, it's black and I feel really dark and I feel really quite breathless and blah, 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 is, oh my God, that the staff can think alarm bells, we need to check, we need to escalate this and say, as opposed to sometime when there's outliers, and there might be people who aren't used to such syndromes, who might just think, oh, lie down there and not realize that there's as much of an issue. So there's big training, as there is with lots and lots of things in relation to hemoglobinopathies, about trying to identify some of these signs and symptoms associated with the hemolysis or delayed transfusion reaction. So how do we treat these? Obviously, if it's in relation to a blood transfusion, you would think that another blood transfusion might not be the greatest thing to do. But in some circumstances, that may be. But the first line treatment is supportive measures. So you do some fluids. You'd also treat with some steroids. So maybe some methylprednisolone in the first instance, and also some intravenous immunoglobulins, normally a couple of days worth of, I think it's 1 milligram per kilo of immunoglobulins, also some erythropoietin, some RNS or something like that, and some hematinics as well, folic acid, etc., to support that. Obviously, with monitoring the patient to make sure that there's no other major issues associated with this, and hopefully that first line treatment will resolve the situation. Second line treatment, if there's still problems, can be with eculizumab, and there are recent, which I don't think you can quite see, there are some recent guidelines of new treatments, including eculizumab and also rituximab now for, and this is basically, I'm looking at adult patients here, for the treatment of hyperhemolysis associated with that. So the first line would be your supportive measures, your steroids and your IVIGs, followed up by, which would hopefully resolve that. And in the cases that we've seen in Liverpool, although there's only been a handful that has worked, but there are now recommendations for second and third line immunosuppression to help with this group of patients. There is also prevention, and prevention is good because potentially some of the where this has happened, certainly with hyperhaemolysis, there's a chance that this may well happen again. So again, prevention, if we know there's an elective transfusion due for a patient who may well have experienced this in the past, IVIGs and steroids in the first line, and then if that's failed or there's further issues, then there's the thought of rituximab, and this will become evident why these things are important. So let's briefly discuss some of the issues. Do we need to transfuse? Yes. Is there a clinical indication? Yes. Do we know how long for? Do we know what type of transfusion? Yes. Are we aware of the side effects? Yes. So we've got that. But and hopefully most of the time things work well and we have the appropriate outcome. But occasionally there are things that happen. So I'm just going to talk about a young lady here of ours. And she's a 35-year-old lady. She has sickle cell disease. Her genotype is SC. About 2013, she had a lacunar infarct. As a teenager, she had a right hip replacement for avascular necrosis, which was a metal-on-metal hip, unfortunately. About 5 years ago, she started with a pseudo tumor, which was associated with this metal-on-metal hip replacement, and she was waiting review from our orthopedic colleagues. We'd also noted previous red cell antibodies, and we were unable to offer any sort of reasonable blood transfusion prophylaxis in relation to a lacunar infarct, just because there was no blood available. She has chronic pain, as we can see from what I said, complex medical issues, but also, unfortunately, very complex social issues. And just to highlight some of the things moving forward with this young lady, last year in 2022, she actually DNA'd 22 appointments. So there's lots of things going on with her. I've been out to the community to see her, and she does go into clinics, but there's an awful lot, as well as her medical issues. There's also some not very nice social issues as well that she's having to put up with. So she saw the orthopedic team, and there's an X-ray where you can see her hip, and also you can see below that what looks like a huge, the size of it when she showed it was the size of a watermelon, this pseudo tumor. She was obviously in pain. She needed the hip joint removing anyway, but this wasn't particularly good. So as surgeons will say, if they see something interesting, yes, we'll do that. We'll get that done ASAP. But thankfully, we said, hang on for a minute. And this potentially caused more emails, the longest email chain I've ever been involved with, because not only is it the patient obviously at the center, there's the orthopedic team, there's the hematology team. With her pre-op planning, she has some interesting red cell antibody screen, which was there. When we contacted the NHS-BT, so that's another group of people to speak to, and that was Dr. Callahan, who's our consultant, and also guys in the laboratories over at Speak in Liverpool. And when they did a search, there was 2 units nationally. So in the whole of the UK, there was 2 probable compatible units that they could have found. So what we needed to do, because this was removing this big pseudo tumor as well as the surgery, we needed to get specific donors. So it took about 12 months, and we managed to get 7 units of blood available for this young lady. Frozen blood bank, which is in Liverpool, stored in Speak, NHS-BT in Speak. So far we'd used Haemoglobinopathy team, we'd used the orthopedic surgeons, obviously the anaesthetist that was involved, the National Blood Service consultant, the National Blood Service frozen blood bank, the preoperative assessment, the ward, then obviously there was the intensive care unit and all the appropriate people about trying to arrange this surgery. So what we did a treatment plan for this girl, just saying what we'd done. And by the 25th of February in 2020, we'd managed to have 7 units of blood available for her. So it wasn't enough to do a partial red cell exchange prior, but we'd given us some, she'd been taking intermittently hydroxycarbamide, and she'd had a slight increase in her hemoglobin. And because this was causing us so many problems, there was the go ahead for the surgery. So again, we got the full plan, and it was because the frozen blood banks take 24 hours to get them defrosted, but they're only then available for 3 days, and it takes such a long time. There was 1,000 phone calls making sure that everyone knew exactly who had to be where, do what, to make sure we could get this blood, this vital blood for this patient to go ahead. So we'd had the plan in place and everything was going ahead, ITU. So surgery was planned for the 18th of the 3rd. We all knew what we were going to do. And then March 2020, what was going on? Well, just at that time, the surgery was postponed. Intensive care units were becoming full of patients with this virus that we were hearing about on the news. Elective, and this was elective, although it was more than elective for the young lady, surgery was being cancelled. There was no guarantee of intensive care jobs. So unfortunately, the surgery was postponed. And it didn't go ahead. It wasn't rescheduled for 12 months, just over 12 months. One of the benefits at this time is that we now had 12 units of blood. So pre-op HB was 97 due to bleeding, because obviously the pseudo-tube had actually got bigger. There was a reasonable amount of blood loss, and they transfused to 3 units of blood during the surgery. Post-operatively, she was doing reasonably okay. She was in some pain, but she was doing okay. And then took a bit of a downward turn. Reviewed overnight, she was hypertensive, she had a tachy, bit of a pyrexia, she was a line infection, she had some red urine, they did some blood, they'd noticed a drop in hemoglobin, and the hemoglobin was 43, so that's quite a significant drop, to say the least. All the presence of a delayed hemolytic transfusion reaction, what hyperhaemolysis, this, she was hemolyzing, she was losing red blood cells. So she was treated as per guidelines. We gave her some methylpred, we gave her some IVIGs, we gave her some Aranesp. About 6 days later, they did actually identify a new antibody. So we could mark it down as a delayed transfusion reaction. But this was happening 14 days post-operatively. That was slightly longer than we initially thought that, or we'd wanted her to be in hospital. It was delayed a little bit because of pain control and a few other little issues socially as well. But if it had been another patient, potentially that patient may well have gone home at that point. But this reaction, this delayed hemolytic transfusion reaction, could well happen if the patient was in hospital. Thankfully, it was detected, she was treated, and it resolved, and she went home. The issues, though, are for this young lady in the future is that she needs the hip replacement that she had was 1 of 2 stages, the first of 2 stage. So she needs that hip replacement. She's also getting quite nasty avascular necrosis of her shoulder. So she's going to need probable surgery for that. So what is the next plan? Well, as I previously mentioned, there is now treatment plans for prevention of such transfusion reactions. So this is a lady that when we've seen more from the orthopedic guys when they are planning, that we will obviously MDT and probably will be treating with rituximab prior to her having some surgery. So I just added at the end, we know there are issues. Shots are involved now, and shots is hazard transfusion have a section on haemoglobinopathies. They're the key messages. Alloimmunization is a significant problem. If you look at the issues with the young lady who's just been in there, that will have been alloimmunization, developing those antibodies. And transfusions, clear guidance. I've discussed that. We know there's clear guidance, and there's other shot recommendations. So I realise I've taken on too much time. So there's lots and lots of things to read. There's guidelines, there's position papers on new treatments, etc. There's lots and lots to find out there. And my final slide is hopefully in 2 weeks' time, that's going to be my new home. It looks slightly different from the centre of Liverpool, and I don't know whether I'll be hearing the police helicopter quite as many times, but I'd just like to thank you guys for listening. I hope you're still there. I've got no idea whether you are. I might just be sat in this room talking to myself for an hour, but I'm happy to try and field, and I'll do my best to take a few questions. Thank you very much indeed.
Thank you, Andy. That was a really thorough presentation. Does anyone have any questions, please? So I just have one question, although I'm not clinical. So earlier on you discussed symptoms of hyperhaemolysis. I cannot even say that word. I was just wondering, are there any other symptoms that are quite common, Andy, that our staff can look out for?
Yeah, with blood transfusion reactions, there can be lots and lots of things to think about. But with hyperhaemolysis or a delayed transfusion reaction like that, that lady's normal hemoglobin was round about the 100 mark, and she had hemolyzed. She'd broken down her cells down to 43. So, you know, she would look, and she did look very, very pale. There was evidence of some breathlessness on exersion. You know, her urine, with these sorts of things, urine is a big thing that goes from a normal colour. Anyone, if they turn around and say, oh God, my urine, it looks really dark or whatever, is an indicator that there's a breakdown of cells and something needs to be done. And testing that urine, and then a simple blood test, a full blood count will say, oh my God, hemoglobin 90 1 minute, 43 the next. We need to do something.
Thank you. Barbara Bailey?
Yes, sorry, can you hear me?
Yes.
Yeah, okay. Andy, I was just wondering, clients that have the hyperhemolysis or the delayed transfusion reaction, is there anything in place already for them to sort of carry their details with them, something like an alert? Because lots of people are going abroad and all sorts of places, and when they have such a disastrous sort of complication, you know, people need to know quickly. So what is out there already for them?
The National Blood Service will provide cards. So if anyone has any weird and wonderful antibody screens, like we saw with that young girl, there's a list of this. The National Blood Service can provide a little card, pretty similar to the sickle cell alert card that we get from the NHR as well. So there are cards like that. We try on our individualized care plan, write a line or a paragraph on there about transfusion history. The first line is normally do not transfuse without contacting hematology in the first instance. But if there's anybody who's got known widespread, antibodies, we will document it on there. We can send that obviously as the letter form to people. We tell people to photograph that, or we'll email those to people so they can keep it on the phone. Because one of the good things about technology, although I don't like the newfangled thingies, is that most people do have phones, so there are mechanisms to get that information out to the patients.
Andy, can I just ask the last thing? Can that be standardized? Because some might be able to access the blood transfusion service, so it might not be consistent out there. That's my other question.
It would be nice to. We do it because they, National Blood Service, tend to send them to us, and then we pass them on to the patient. So I don't know what other individual centres do, whether they would have that, and that, you know, it would be sent to their transfusion laboratory, would then send it to me or the CNSs, who can then pass it to the patients. It would be something that I suppose it might be a point to take up with the NHSBT, that for patients who do have these weird and wonderful, and it's not only our hemoglobinopathy patients, there's lots of other patients who've had issues, or people that need red blood cells, for instance, for IgG deficiency, whether there's any mechanism for them to forward them directly to patients or even to GPs, which could then send them to their individual patients. So I know the NHSBT do have liaison people there, so I'm quite happy to pass that on to them.
Thank you so much. That's marvellous. Thank you.
Pleasure.
Thank you. Is there any more questions before we finish the session? No, okay. Well, thank you all so much for attending this afternoon session, and a big thank you for Andy. Really appreciate it's a very thorough session.
Thank you.
You've got a few claps there. If anyone would be able to provide any feedback on the session, that would be great. I have attached a form there, and certificates will be given once we receive the feedback. Thank you so much.
Thank you very much, guys.
Bye.
Bye.